Waiting for the cue.
Hi, and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And welcome back. I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network.
As always, if you're following along with us live, please feel free to ask questions or comments here on Twitter, Facebook, or comment below on YouTube.
Right. And we will post links to the articles we discuss after the live broadcast, so you can read the articles yourselves, view the video at your leisure, and leave comments afterwards, which we'll monitor and get back to you if we can.
Great.
We have two articles again this week.
Yep, and of course we've got another author visiting us. We've got
awesome.
Yeah, that's great. The article we're covering is Association Between Pharmacy Closures and Adherence to Cardiovascular Medications Among Older U.S. Adults by Dabigatran and colleagues.
And Seth, just this title surprised me because all I see is more and more pharmacies. So I was kind of surprised to hear that pharmacies are actually closing.
Right. Well, why don't you ask Dr. Cato what's been
Dr.
going?
Cato, welcome and thanks for your contribution to the journal and for your work. Can you tell us what you did and why you did it?
Sure. So we were interested in understanding the role of closures on medication adherence, specifically in the elderly. We know a lot about prescription drug costs, affordability, and how it impacts adherence, but we know very little on other community level factors, system level factors that may impact the ability of a patient to adhere to the medications. So you mentioned that pharmacies are opening around the country, and they are, but they're also closing in some neighborhoods more than others. So in the context of disparities and particularly persistent disparities in adherence, it was important for us to understand whether pharmacy closures, it was a simple question, when pharmacies close, what do patients do? And does their adherence worsen compared to patients that don't have to experience a closure?
Okay. And it looks like you used the IQVIA database to assess basically what prescriptions claims were done, and then whether or not adherence was measured, or how adherence was both before and then after a pharmacy closure, and compared to a bunch of patients who didn't have closures as a control. How did you measure adherence in the study? Tell me about that. That was interesting to me.
We looked at monthly adherence, so 12 months prior to a store closure and 12 months after a store closed compared to the control group. And the measure was the proportion of days covered, which looked at basically the number of pills over 30 days. So it's based on day supply. So it's kind of the diary approach of medications.
And which subset of medications were you looking at?
So we looked at statins, beta blockers, and oral anticoagulants.
Okay, and tell us what you found.
So surprisingly, not surprisingly, but we found an immediate decline in adherence for patients that experienced a closure. And that decline persisted. It was about a 6% absolute change post-closure that began immediately after the store closed and then continued really and persisted over a 12-month period.
Yeah, and I think that's illustrated pretty well in figure 2, which we can show for the viewers. And it looks like adherence was about in the around 75% before the closure, 70% before the closures, and then dropped by those 6 absolute percentage points with the closure. One of the small things I found interesting was how there was more likely to be a drop in adherence if the patient needed their prescription within 2 weeks after the closure, but if they had a month, then they basically seems like had extra time to figure stuff out, figure out where to get their prescription rerouted, get all that stuff done, which to me makes a ton of sense. I mean, this all makes sense to me because there's just so many steps that need to happen correctly to get your prescription filled. You need to get diagnosed, get prescribed, get it to the pharmacy, make sure it's covered, make sure you can pay the out-of-pocket, get it filled, take it home, take it, all that stuff. Like part of my shtick when I'm talking with patients about this stuff is, you can have the best drug in the world, but if it's causing side effects or you can't afford the parking at the pharmacy to pick it up, then it's no good.
Right.
Exactly. Yeah. So I'm glad you mentioned the 2-week kind of cutoff where we found, like after 30 days, there was like a 2% decline. But within 2 weeks, if a refill was due, the 2 weeks after the pharmacy closed, we saw the most kind of dramatic decline, around 14%. And when we look at what pharmacies do usually in cases of closures, there's usually that 2-week window where they inform patients, right? But if you don't have a prescription due within that 2-week window before the closure, you're not going to know. which indicates that there's more awareness that needs to be done in terms of connecting patients to other pharmacies that are more as convenient as this pharmacy that closed that they were using.
One of the interesting findings I thought was that I think close to 40% of the pharmacy closures were independent pharmacies, not parts of chains. Is that right?
Right.
And so that seems like maybe it's not a dying breed, the kind of the independent compounding pharmacy or the kind of family-owned pharmacy, but it seems that way in terms of the kind of growth of CVS and Rite Aid and all of these other kinds of commercial pharmacies. And I wanted to know whether you had any sense for that, whether this is kind of like a dying aspect of kind of, street or neighborhood pharmacy services for these communities. I know that goes a little beyond your study.
Right. Yeah. I mean, we're working on a separate study that's looking at predictors of closures, which would better answer that question. But I think what's important to note is that, independents are closing. More patients that are using one of these drug classes that are using an independent if they're going to be experiencing closure. But we do see some chains closing, right? Mm-hmm. So it's also affecting chains. And it's actually affecting, if you look at kind of over time, more and more chains are closing now than they did in the past. And I think chains matter because unlike independents, they offer other services, whether it's preventive care, even clinics, right? Minute clinics and the other types of clinics and services they provide. So when they do close, it not only impacts access to prescription drugs or adherence, it could potentially impact other important aspects of healthcare. Mm-hmm.
Yeah, it was interesting to me, too, how some of the other subgroup differences that, some obvious things like neighborhoods with fewer pharmacies had a slightly higher rate of drop in adherence. But not surprisingly, patients who use non-retail channels like mail order weren't affected by closures as much because they aren't really affected if it closes. But also, not surprisingly, difference with the retail pharmacies that, if your local CVS closes, it's probably at least more familiar to go to another CVS. And I would imagine you could probably speak more to this, that, it's in their system. They can find your prescription. It's one less step of hassle to get your prescription filled at a new place.
Exactly. So we did find that for chains, just back to that point about independence versus chains, for chains in low access areas, so neighborhoods that have fewer pharmacies, when their chain closes, that effect, even though they have integrated systems, the effect of closure on adherence is much worse in those low access neighborhoods than if a chain closes in a higher access. And that makes sense in terms of, just because they transfer it to another chain, that chain may be further away because most chains don't, in low access neighborhoods, it's mostly independents that are in those areas and not chains. Right. So when that lone chain store closes, the impacts are pretty much worse.
And you had mentioned disparities earlier. There are obviously pharmacy disparities by the nature of what we're talking about. Were there the typical kind of racial and socioeconomic disparities in terms of these pharmacy closures in your study?
So baseline adherence levels were as expected. They showed disparities, right, in terms of, predominantly Black communities have worse adherence than predominantly white. But what was interesting is that once a pharmacy closes, you really don't see the differential effect based on community type. Mm-hmm. It's more about whether it was a Medicaid patient, it was whether they used a chain or independent, whether they lived in a low access neighborhood or not. So again, goes back to it's really about community resources. And if you're in a predominantly white neighborhood and it's a low access neighborhood, you're going to deal with the same struggles as someone in a predominantly Black neighborhood that's also low access.
Right. Yeah, I found that interesting also how there's no difference across income, but the payer status. So if you were low income, it didn't make a difference whether there's a closure or there weren't different rates in closure was lower and less low income, but there was a difference in Medicaid versus other insurers. And I feel like, to me, that resonates as we use a lot of these very blunt tools of measures of socioeconomic status that don't tease out a lot of different detail. But now that we have things like how many pharmacy, what's the pharmacy density in your neighborhood or what's your payer status and things like that, then that does kind of get more to the specifics of your case.
Great. And so are policy implications or next steps?
Yeah, so there's a few, I think, implications. One, the obvious one is that when we're trying to improve adherence, we should consider the role of not just pharmacy access, but specifically pharmacy closures. So one thing that we didn't really highlight in the paper, but we found is that initially we came in thinking there's going to be differences in adherence based on pharmacy access alone. And we really didn't find those substantially different, across low access versus high. And that was pretty surprising, but it makes sense, right? People they accommodate their daily schedules, their lives with whatever they have. But when a closure happens, it's those low access communities that are affected, right? So I think incorporating closures, and for example, Medicare Part D has pharmacy access standards that their health plans have to comply with. And we recommend kind of expanding that to include some sort of aspect of pharmacy closures, and making sure that pharmacy access is monitored continuously and closures are accounted for. That's one. I think another is just outreach, more direct outreach to patients. Once a pharmacy, so pharmacies their closures are usually planned in advance, but patients may not be aware of that. And there's really, other than the 2-week notice for most states, there's no policies that require pharmacies or plans to notify patients that, hey, the pharmacy you've been going to for the last 10 years is closing tomorrow or in a week. And we know as a pharmacy that you have a refill in a few weeks, right? So I think pharmacies, whether it's through their refill management tools or whatever outreach activities they have, should kind of really target patients, especially those that we know, for example, live in low access neighborhoods that are most affected, and make sure that they kind of transition from the closure to whatever pharmacy is convenient, including maybe mail order. Maybe that could be an option, or delivery. Those are some of the recommendations we make.
Right. Well, that sounds like a lot of, I'm an optimist, so a lot of opportunities for improvement still left. So this is a really interesting paper, really great talking to you. Thanks for joining us.
Thank you for having me.
Great to see you.
Yep.
Thanks.
Great.
What do you have next?
Take care. Next, we've got another clinical pharmacy paper.
Yes.
Safety and efficacy of minimally interrupted Dabigatran versus uninterrupted Warfarin therapy in adults undergoing atrial fibrillation catheter ablation, a randomized controlled trial by Nagomi and colleagues.
Right. So these are patients who are on the anticoagulants for their AFib and are undergoing what they hope and we hope are the definitive procedure, which is catheter ablation.
Right.
This is one of these kind of comparative effectiveness studies, which we used to see a lot more of when it was a kind of a priority of the funding agencies, and we would love to see more of these in the pages of the journal.
Right. Yep. Everyone likes a good RCT. This is nice too because we grew up in the era where basically heparin and warfarin were the only anticoagulants.
Right.
And now we've got a bunch of newer agents, which I like the term DOACs, not NOACs, because at some point they're going to stop being novel, and we can't call them novel agents forever.
Okay.
Although we probably will.
They will always be novel relative to warfarin.
Yes, that's true. But what's next? Like ultra novel? What's the next way to call it?
Right.
Right. But anyway, what they did is they basically randomized patients to either get Dabigatran or Warfarin for a few months before their ablation, and they continued for, they followed them for 90 days. They kept the patients on Warfarin throughout, and following guidelines. Apparently, there's guidelines about skipping 1 or 2 doses of Dabigatran before the procedure to help minimize bleeding, even though it's a low-risk bleeding procedure. The primary outcome was, were there any thromboembolic events at all, and then the secondary outcomes are things like bleeding complications and other usual bad things that happen to patients when we do stuff to them.
Right, the typical clot versus bleeding, protective benefit versus risk kind of comparison for these two. And what did they see?
So primary outcome is that Dabigatran was as safe, as effective as effective as Warfarin. There were basically statistically the same amount of thromboembolic events. In their roughly 500 patients, there were actually no thromboembolic events in the Dabigatran group. And then there was 1 left atrial thrombus in the Warfarin group, so basically wasn't effective in stopping a clot from forming before the procedure, which is when we worry about putting them back in sinus and then kicking that clot out to cause a stroke in our hand-waving physiology part of the class. And then there was 1 patient who had a stroke on Warfarin, and notably their INR was 1.56 at the time.
So this is the complicated kind of methods where you have almost 0 events, and then you have to figure out whether that's representative of kind of a broader population, whether you can draw inferences from it, or whether if you have truly 0 events as a comparison, then you're really stuck. Right. Then you have an underpowered study.
But it's good. But this is also a situation where we have 2 drugs that we know are pretty effective. Dabigatran is a little more expensive. We have less experience reversing it. We have less experience with it overall. So side effects for Warfarin are very well described because we've been using it for decades.
Right.
But it's also really cheap. On the other hand, is rat poison. So.
Right. And some people have said that, and this is an older argument now because we have accumulating experience with these DOACs, and they do, based on the evidence, seem to be effective and maybe a bit safer than warfarin, is kind of the accumulating picture that we're gathering. But some people continue to feel that warfarin, by virtue of requiring INR checks and getting patients to get into settings where they have to have their blood drawn, kind of draws them into the healthcare system, which has kind of indirect beneficial effects for the rest of their health because they're seeing doctors or they're seeing health professionals and checking in more often.
Yeah, I know, but having to get your blood checked every 2 weeks for a medication that changes if you eat too many vegetables, eat your spinach, and by the way, you might die.
Yeah, that is true, but I'm not sure. Well, I'm not going to get into it too deeply, but I'm not sure how true that is. It does go up and down. I'm not sure how diet sensitive it is in the global population. There is that kind of thought.
Sure. I think it's funny or it's amusing to me when the DOACs first came out and we talked about it's like, look, we don't know if they're working. We don't have anything to monitor it. We don't have any reversal agents, although now reversal agents are coming out, although there's some questions about their clinical efficacy, not just lab efficacy for these. But I have a colleague who puts it really well where if we had started with the DOACs and this new drug came out that, hey, by the way, it's rat poison, you have to have the levels checked every 2 weeks and it might change all the time. We don't really know. But there's probably reversal agents that work pretty well over a number of hours, but they're thousands of dollars.
Yes.
We wouldn't, at that point, it wouldn't be an obvious switch to warfarin.
Right.
So, remembering the status quo bias, I think, is important here. Ultimately, neither of these are none of the things that affect bleeding are perfect at all. So I think having a range of options is helpful, and the more data we accrue, the better. What was interesting to me was that the secondary outcomes here on bleeding did show lower rates in Dabigatran that were, technically statistically significant. There were 3 bleeding events in the Dabigatran group and 11 in the warfarin group, which was enough to cross the p-value thresholds. 3 out of about 240 and 11 out of about 240. And these are things like there's 1 pericardial effusion in each group. There's 1 femoral AV fistula in the Dabigatran group and 1 intraperitoneal bleed. In the warfarin group, there was 3 groin bleeds, 1 AV fistula, 1 pseudoaneurysm, 1 RP bleed, some subQ bleeding, 1 compartment syndrome, and 1 tamponade. So there was some bleeding, and there was a little bit more in the warfarin group. So I think my takeaway is that based on this, Dabigatran seems about as safe as warfarin, at least as safe as warfarin, based on these numbers, which is reassuring. It's effective, seems to work.
But I'm going to ask for clarification because this is called safety and efficacy of minimally interrupted. I call it Dabigatran. You say Dabigatran. Which do you like? Is the emphasis on minimally interrupted, which is that you skip 2 doses, or can you just continue the drug?
So I'm not a cardiologist. I'm certainly not a hematologist.
And you're not a cardiac electrophysiologist either.
I am also not a cardiac electrophysiologist. Right. But basically from reading the interim background here, there's nobody really knows that. It hasn't been studied enough to know if you should skip 1 or 2 doses or not. And this is basically based on some guideline recommendations from a couple different groups. And they say, why don't you just skip 2 doses of Dabigatran while we poke you?
Right. Got it. So I guess my take on this is that it is another pixel, meaning a picture element in a larger picture that again suggests that these direct oral anticoagulants, in this case Dabigatran, is probably as effective and maybe safer than warfarin. It's not in and of itself a signal that you should be switching patients from warfarin to Dabigatran, or that this is the approach that you should be taking in a lead-in to afibrillation, but that it's kind of more evidence kind of on the side of Dabigatran as a useful and reasonable option for these patients.
Right, exactly. And it's also interesting to me because there seems to be a bit of a tide shift towards the 10A inhibitors, the
Fondaparinux?
No, apixaban and rivaroxaban,
Yes.
as opposed to Dabigatran. Dabigatran's twice daily. I think there's some pharmacodynamics reasons that are above my head because I don't really prescribe these very much. But there seems to be a slight move towards those. They're also a little newer and probably marketed a little better. I should also note there was only 1 death in the whole study, and that was a cardiac arrest of unknown cause in the post-procedure period a few weeks out in the warfarin group. Not enough to say there's a difference in death between 1 and 0 out of 250 some odd patients.
Right.
But, if we talk about bleeding, I should mention the 1 guy who died.
Right. And we should probably also mention that this is a Japanese clinical trial. So these are a Japanese population. No reason to think it's substantially different from populations elsewhere, but this is a international trial. which we love.
Yeah, and again, in the complex world of anticoagulation, it's better to have more tools in your tool belt that work, and it seems like Dabigatran works pretty well.
Awesome.
Yeah.
Thanks.
All right, great. So that's the two papers we're going to cover in depth today. We do have a bunch of other things to talk about from last week's release. The first one we're going to talk about, just because there's some cool imaging here, there's a study where they looked at doing, instead of just the kind of typical CT and MR axial imaging for Wilms tumors to surgery planning, they did 3D printing and augmented reality holograms using, I think it was the Microsoft 3D goggles.
Yes, called the HoloLens.
Yeah. And basically did a quick qualitative study of asking about, I think it was a half dozen or so surgeons if it helped with their planning, and they could look at the 3D models they printed. They could manipulate the kidney and the tumor in space, look at the vasculature, the complex relationships, which to me seems intuitively obvious as a non-surgeon that if you've got a 3D model that's got some fidelity to it, that's better to look at than just thin slices that go up and down.
So this is, I think, a real trend in medicine. I don't know. Do you know the difference between virtual reality, augmented reality, and integrated reality?
I've never heard the term integrated reality.
Okay.
My understanding with augmented reality versus virtual reality is in virtual reality, you're just kind of like, you're totally closed off from the real world and you're looking in a virtual room with virtual objects in it. With augmented reality, like in the video here, you've got your kidney and tumor floating in like the real space.
Got it.
Or seeming to float in the real
So
space.
you are correct about virtual reality. You're completely enclosed. That's the Oculus headset. Your senses are completely devoted to an imaginary space that's electronically defined. So this may be augmented reality. I consider this integrated reality. My understanding is that augmented reality is like Pokemon Go. You have your phone, you're looking at your phone, and you see this virtual thing along with some representation of real life through your camera. And integrated reality is this Microsoft HoloLens where you actually, it's the headset and you're in space, but you can actually move through virtual objects, like this Wilms tumor. And so that's the idea, is that it's supposed to help surgeons plan for procedures. This is one specific instance of that. Another instance is that actually, and I'm excited to see this more generally, maybe at our journal, I've been asking maybe we can implement this, is that all CT and MR scans have 3D data. And all we need to do in order to kind of do better data representation and visual representation is to find a way to publish that in 3D. So you can put on one of these devices and actually walk through the brain in 3D based on CT data, the data that are collected in the scans we're doing today. And I think that's going to be a huge advance, both for clinical care as well as for kind of prepping for procedures when the time comes.
Yeah, and I remember casual discussions in med school with some of the radiologists and surgeons about this when you see these really cool 3D reconstructions from CTs and stuff like that. And it looks really cool, but at this stage, it doesn't. At that stage, back when I was in med school, it didn't add a ton. It just looked cool, and they could show patients, and everyone thinks it's great.
Right.
If it's something, to me, for something like a Wilms tumor that you're going to excise, and there's vasculature all around, and you got to figure out what's integrated into what, that makes sense to have more of a 3D mold, and it seems like we're getting closer to that being something where these 3D reconstructions are helpful.
Right. Awesome.
Pretty cool. Yeah. So some of the other things to look through, our featured article this week is a paper looking at the data sharing and privacy practices of smartphone apps for depression and smoking cessation. And they looked at a couple dozen apps, and unfortunately, some of them were basically sharing, maybe selling your data to Facebook and things like that in ways that weren't necessarily disclosed in the privacy stuff. Basically, I don't know, more kind of typical expected shadiness, and nothing online on your phone or anything is private ever, and all your data is out there.
Right. Was the issue in this paper that they weren't communicating that, or were people clicking agree and agreeing actually to share their data?
Some of it was definitely not disclosed at all.
Okay.
So that's definitely an issue. And the giant end user license agreement that you just click through because you couldn't possibly read is an unfortunate reality. And I don't know. From what the lawyers tell me, it's a contract and you signed it, whether or not you read all 40,000 words.
I mean, it's really hard to be online and to use these without actually compromising some of your information.
Yep, so everything's out there. There's a study here by Adam Singer, Henry Thode, and Jesse Pines, who I've worked with before, looking at US ED visits before and after, or US ED visits and hospital discharges before and after the ACA among uninsured patients. There are a lot of papers that have shown this in kind of different bits and pieces, but again, they're showing that main difference in emergency department visits and hospital admissions before and after the ACA was that the percentage of visits that were uninsured went down and was basically replaced by primarily patients with Medicaid. In general, everything we've seen shows basically the growth in ED visits has been pretty linear through time. Wasn't really affected by the ACA, but instead of getting no money, hospitals are getting some money
right.
from Medicaid.
Yes, at reduced usual and customary or whatever.
Yeah, and this was a bit interesting because it also looks to hospital discharges, and as an ED doc, most of the literature I know is just about the ED visits, so it's nice to see them two together. Next one looked up, this is one of the slices from the Framingham study. They looked at accelerometer measured light intensity physical activity and how it impacted brain volume later in life, which we think is probably some sort of surrogate of dementia and aging. And that, not surprisingly, if you do more physical activity, your brain looks better.
Get moving.
Yeah. It turned out that exercise is good for you. There's another one here looking at occupational pesticide exposure and its relationship with immunochemotherapy response in patients with diffuse large B-cell lymphoma. And basically, people with diffuse large B-cell lymphoma who got immunotherapy,
who were exposed to pesticides,
did worse.
What's that sample? Do you remember how many
It's
patients
3 guys.
Okay.
No, but I mean, it's one of those things where it always seems abstract to me when you talk about like organophosphate poisoning on the board and stuff like that. But there are a lot of people, like there's a lot of farmland in America. There's a lot of people who work along pesticides. There's a lot of non-farm pesticide use. People do get exposed to stuff. There's a third of a billion people in America and a lot more people worldwide. Some people are actually exposed on a daily basis to low levels of pesticides. Having one more piece of data is helpful. But again, you're right. This is kind of slight. We're making some pretty thin slices here.
Okay.
Another one here looking at the association of maternal cigarette smoking and cessation with preterm birth. Turns out smoking
not good.
Smoking is not good for you. And basically looked at women who quit smoking before pregnancy or during pregnancy and found that they had lower rates of preterm labor than women who continued to smoke.
Is that a surprise? Like what's...
I mean, not a surprise. I don't really know the links between smoking and preterm labor, but preterm labor bad, and much of it seems preventable. Not all, I guess.
Right.
And smoking is bad and seems to be bad in a dose-respondent way. And this seems more data on a thin slice of that.
Okay.
And just also, I think part of it, and this is part of what I talk to patients about too, is they're not kidding when cigarettes are. Or when they say cigarettes are really addictive, cutting down is better than not. Quitting is the best thing you do. Cutting down is better than not cutting down. And smoking's bad. Less smoking is less bad.
Right. And I used to tell my patients, I used to put it in the terms of the money they'd save, right? How much money, more money they'd have in their pocket.
Yeah. And then last one, as required by law, we have to talk about opioids. This is a kind of sad paper that they basically looked at opioid dose variability on patients on chronic opioids and found that you are more likely to have an opioid overdose if there is variability in your dose over time, which is not surprising that if your dose goes down and then for whatever reason you get a bigger dose or you're less accustomed to your higher dose, you're more likely to overdose for whatever reason. So again, one more pixel in the overall JPEG of our understanding of opioids.
Right. Okay, so I think that's the wrap up.
Yeah, that's it for today. Thank you for joining us. As always, these papers and more are all free on free and open access at JAMA-networkopen.com. We will be back next week. We should be here Monday the 29th at 2 p.m. as well. Please be sure to follow us on all your social channels, Twitter, Facebook, LinkedIn. Watch our videos, comment, send us questions, concerns, funny cat pictures.
Right. Check out our podcast. Check out our translations of our titles and key points. And check back on Friday at 10 a.m. Central or GMT -5 for the next set of articles in this new and growing general medical journal called JAMA Network Open.
Take care.
Thanks for joining us. Take care.